Pooja, before we begin, just ask Dr. Bali to click on the height. That bar always is at the bottom.
Okay. Now it's okay. Is it okay? So, am I audible?
Yes, sir.
How do I go about that? How will it?
Ajay sir, we can plan the next class as not an academic one.
Yeah, absolutely. I'm all for it.
So we start from the first 2-3 batches and then move downwards.
Absolutely. Those days there were, I think, 1 or 2 per batch.
Okay.
So if you're going to have 10, maybe 4 at one time we can
So I
take.
mute my.
We can have maximum of, I think, 6 or
Okay.
10 people at one time.
Yeah,
And then we can have 4 academic sessions, and then again we'll have the next 10 people.
absolutely. Absolutely. I think it's a great idea and it'll be fun.
This started as, it started as I had a forum which was PGI Cardio Masti.
I'm okay.
It's
So
the
I
idea.
go back to
started
the
from there.
presentation. Is that right?
तुमने हमको ऑलरेडी बुड्ढे बुड्ढे लोगों की कैटेगरी डाल दिया उस मस्ती वाले ग्रुप में तुम्हारा नाम है ही नहीं.
नहीं, मस्ती वाला ग्रुप अब रहा नहीं, वो फिर कन्वर्ट हो गया एकेडमिक्स में. And then we continued that as academic. Resident थे तब तक मस्ती वाला ग्रुप था.
अच्छा, okay.
Am I audible?
Yes, sir.
Yes, sir. Yes.
So we can start whenever you are ready, sir.
मैं देख लूँगा.
Yeah, he's on. Clear. So can we start? Sure.
Smith, I presume you're talking to Pooja.
Ajay sir, we can start. So
Yeah. So, am I audible?
Yes, sir.
Everybody just right. Bali sir, with your permission, may we start? Bali sir, are we clear? Smith, can you just call Pooja and ask if sir is able to hear us?
Yeah.
Is his mic muted? I don't see his mic unmuted on screen. I can see his presentation on screen, so that should be fine.
Meda. Ajay sir, are you able to listen to me?
Yes.
Hello.
Yes, Dr.
But
Pant,
I'm not able to see your faces.
Okay, so I can see Dr. Chaliha, Dr. Bali, Dr. Jay, Dr. Smith, and yourself. So
Okay, but
maybe
it's not in my screen. Yeah.
So just enable your video. It will be on the
Thank
right side in the corner. I can see Dr. Bali's
See, I
first
can
slide
see the
also.
slides. I can see the slides of Bali sir, but not the faces.
So you see the layout on top of your screen. There will be a tab for layout, and you can see that maybe they have put only the slide. That is why the participants are not seen.
Right, sir. Right. Thank you.
Maina.
Smith, any luck contacting Pooja?
Yeah, sir. She's actually her phone is not ringing.
Oh, okay.
I'm just trying.
Maina. Maina.
Yes, Pooja. I can't hear anybody, and I don't know whether anybody is hearing me, or should I start?
Sir,
We can hear you.
we can hear you, sir, and we can see you also.
You can hear me.
So we
Okay,
can hear you
right.
and see you also. Yes.
Good evening, everybody. And it's been a pleasure talking to you after such a long time. Some of you may be knowing me, but it's almost 13 years since I left PGI, so many may not be knowing me. This is 1992, the year when the journey started as a faculty in PGI, and some of you may be able to remember a few of the familiar faces. Our faculty here, Professor Bidwai in the center, and we were talking about Dr. Khatri. Yesterday, he's on the left of Dr. Bidwai, and I can see Dr. Chaudhary, Dr. Nisar, Dr. Parle, Dr. Amothan, and then the cath lab team, and we have Dr. Naresh Sood, Miraji Rao, Tushar, and I can recall some of them, and I think you would be able to recall everybody. Now, coming to the topic today, when we talk of elderly, they do not have only coronary artery disease. They have peripheral artery disease. They may have significant carotid artery stenosis. Some of them have infrarenal aortic aneurysm, thoracic aneurysm, severe aortic stenosis, calcific, degenerative, about which we may have some talk today, and mitral annular calcification as well. Previously, when I was doing my DM, it was thought that above 65 years, you should not be doing bypass, and you should not be doing angioplasty, you should not be doing transplant, but that was a long, long time ago. And we have paucity of data of doing procedures in elderly. One of the major reasons is that the trials do not include elderly people, and we have to go to the registry to find out what's happening to them. And worldwide, if you see, elderly population is increasing. In India, although 65% people are less than 35 years, but the elderly population above 80 years is also increasing rapidly. We also need to understand that PCI has become safer, and hardware has become very user-friendly. In fact, anybody can do angioplasty these days. Not great technique is required. What is required is where we should be doing, in which patient we should be doing, and for a long-term benefit, for not only quality of care improvement, symptom relief, improvement in effort tolerance, but also in improving longevity. That is what we need to remember, and we should be doing for long-term benefit. The era when we used to talk about I can do CTO bifurcation is gone. Today is not that everybody can do most of the lesion, but patients are more important, and we should be seeing what is best for them in the long term. When we talk of elderly, very elderly, in fact, more than 80 years, you would find there are patient-related risk factors. Some people of them are diabetic, renal failure is common, heart failure with age, heart failure with preserved ejection fraction is not uncommon, and some of them may be actually very old and frail. When we talk of coronary artery lesions, we may have a unprotected left main, venous grout, bifurcation, CTO, multi-vessel PCI, everything is seen. And the presentation can be as acute myocardial infarction, which may be ST elevation, non-ST elevation. Some may present with shock, and rarely they present with the stable coronary artery, what we call as the chronic coronary artery disease. When we talk, as I mentioned, comorbid conditions are common, multi-vessel disease is common, calcification is common. We also need to remember that their hematological parameters may be significantly deranged. Some of them may have elevated or abnormal coagulation factors. Platelets may be hypo or hyperreacted. There may be enhanced fibrinolysis, and there may be increased blood viscosity. We also need to remember that most of the drugs which we use, whether they are antiplatelet or other medicine, have been studied in young population less than 65 years. Some of them are excreted through liver, other through kidneys, and everything in the drug pharmacokinetics may be altered in the elderly. You may have a decreased hepatic clearance. You may have, because of liver disease, you may have decreased renal clearance. Renal failure is not, or uncompromised kidney function is not uncommon. You may have alteration in protein binding, so more free drug may be available. You may have altered volume of distribution, and sometimes the receptor number and sensitivity may also be altered. All of you are aware that many patients in elderly beyond 80 years present late. They have atypical feature. Chest pain may be present, heart failure may be the only symptom. They may have only unexplained malaise, and history is not very reliable because we depend on the time on which the onset of ST elevation myocardial infarction occur, but history may not be reliable because of pre-existing dementia or acute delirium because of altered hemodynamics. And there is a high prevalence of shock in these patients. We rely on ECG. Again, ECG may show equivocal changes. There may be a pre-existing bundle branch block. There may be residual ST depression or elevation because of pre-myocardial infarction. And we, most of the time, in ST elevation myocardial infarction, more often than non-ST elevation myocardial infarction, do take patients straight to the cath lab. And creatinine is very important, electrolyte levels are very important, hemoglobin level is important, and so the coagulation profile. But none of them may be available to us when we take them to the cath lab. This is okay, are acceptable in young patients, but in elderly, these may be significantly changed, and they may affect the outcome much more than the procedure itself. So we need to be concerned about these features when we take them up. And we may have native coronary artery disease of any type. We have venous graft, we have instant restenosis because of previous PCI, or we may have to do multiple PCI. One of the oldest patients which I undertook for angioplasty stenting, this was 2 years ago, was 102-year-old Mataji. And she was a very interesting and a very positive person. When we looked at the family of this patient, she had 5 generations. Grand old Mataji had an incredible family, a very likable family. And we did a procedure through the radial route, and she did very well, and that is gave us a lot of satisfaction. When I was in PGI in 1999, we had done an angioplasty on a very elderly Sadhuji who had thousands of followers. I do not know what exact age he was. It was told to be 126. Somebody said 135. And now the literature says that this patient may be actually even older than that. But I think such claims are made every day in India. But I would say he was a very elderly gentleman. And that is, we did it in 1999. So I will share some of the experience of doing angioplasty stenting in elderly patients. 85-year-old male, 15 years post CABG, presented with progressive angina. This is the left coronary system which is occluded. Look at the native right coronary artery. Diffusely diseased, heavily calcified artery. and that is what was the cause of symptom. And Lima and venous graft to OM was normal, and we went ahead and did an angioplasty stenting of the diffusely diseased calcified coronary artery disease. Because of extensive calcification, we had to use a guide liner, and after putting in 3 stents, we got a very good result, and the patient is doing well. A 90-year-old doctor, a practicing physician, presenting with crescendo angina 13 years after a bypass surgery. We did an angiography, Lima to LAD was okay, but there was a critical left main stenosis, and that was supplying the circumflex, and diagonal also was a large vessel. So because of his crescendo angina, which was limiting him severely, we decided to do a bifurcation angioplasty stenting of left main and diverting the stent to diagonal. And that is what we did. Did an angioplasty stenting, put in a stent from left main to circumflex, put a stent in the diagonal, and then did a part after angioplasty stenting, and this is what we got, and he has been asymptomatic. Now, 82-year-old male patient presented with triple vessel disease within a month after doing bypass surgery, class 4 angina. In fact, angina was much worse after the bypass surgery than it was before the surgery. And we did the procedure, and it is important to remember that it is important to discuss with the cardiac surgeon that where the grafts are required. Now look at this right coronary of this patient. He has a right coronary critical stenosis, and he has a distal right coronary, very large vessel, and he had a PDA which was grafted, and you see a stenosis at the origin of PDA, and this is supplying only the PDA. The rest of the large PLV is not supplied, and that was the cause of his angina, which was very severe, and we had to do an angioplasty stenting of native right coronary a month after a bypass surgery, and look at the posterior lateral ventricle branch and see the vessel which has been grafted. That continues to be supplied by the graft, but the large vessel had to be taken care by angioplasty. An 83-year-old male, 8 years post bypass, presented with acute coronary syndrome, and this is what we looked at the bypass graft, and there is a degenerated venous graft, critical stenosis. Also do look at the anastomotic side, there is a critical stenosis. So we did an angioplasty stenting. You can appreciate that there was not much area to put in a distal protection device in this patient. We put in 2 stents, and the patient did very well. An 82-year-old male presented with acute coronary syndrome and left ventricle failure. Trough was significantly elevated. And this is a graft to diagonal, which is a critically ulcerated plaque, a lot of thrombus, and we put in a distal protection device. You can see the distal protection device here, a spider distal protection device, and did an angioplasty stenting and post-dilated that, and this patient got well. So 89-year-old male patient, he presented to us with cardiogenic shock. He had undergone a bypass about 20 years back, and he had got a CT angio sometime back, and we had known that there was only one patent SVG2 PDA, and he was surviving on that with ejection fraction of 15%. He came with acute coronary syndrome and cardiogenic shock. Blood pressure was 80/60 on maximum inotropes. Look at this venous graft, which is the only functioning venous graft. Lot of clot, critical stenosis, ischemic grade 1 flow into the right coronary. So we put in a export catheter, and after a few runs, we had some flow established. And then we put in a distal protection device. You can see the distal protection device, and you see a critical stenosis here. And we put in 2 stents to take care of this only functional after balloon angioplasty and then after stenting. And you see a lesion distally also, that was also taken care of. And this patient's only functional graft was blood flow was established, and he got out of the cardiogenic shock and remained quite well. Now, 85-year-old male patient presented with progressive angina and left ventricular dysfunction. He had diffusely diseased, chronically occluded right coronary SVG. Normally, we do not like to open up these chronically occluded venous grafts, but this patient was very significantly symptomatic, and that looked to be the reason for his angina. So we used a combined antegrade and retrograde angio to describe how do we go about this. You'll see this venous graft to RCA, and this is diffuse disease, small thin vessel, and you don't see the distal vessel of RCA. So we had to use the left coronary native injection to define where is the PDA to guide us to negotiate the guide wires into that PDA. And after that, you can see the PDA here. And this is what we used as a landmark to get into this. We got the wire there. And after doing angioplasty and putting in 3 long stents, we were done. And this is what we got finally, totally reconstructed venous graft with 3 stents. Now, 82-year-old male had a bypass surgery in 1988, had a redo bypass surgery in 1999, and we knew what were his arteries like, and he was asymptomatic till about 2014. Then he presented with acute coronary syndrome with markedly elevated top level. And you see this venous graft to the PDA, and you faintly see the PLV. And this we knew was a very large vessel from his previous angiogram. Angioplasty stenting of this particular vessel. Now, how do we go about it? There are 2 acute bends here, and this is what it looked like. We had to go antegrade through venous graft, then back, and then take another graft to take care of this area, which was the culprit vessel. So I called it a Z angioplasty, and we proceeded to go ahead. This is a wire which was easy to negotiate. Then microcatheter was taken. A wire was okay, but negotiating balloon was tough. But we were able to get balloon there, do an angioplasty. But after angioplasty, it was just not possible to maneuver any stent towards this double bend. And so what I had to do, this is a time when guideliner was not available. I took the guide catheter right till the mouth of this anastomotic site. And using that as a support, I was able to negotiate a small stent, 3x12, and then another stent to reconstruct this vessel. And this is the stent, and you can see the stent being deployed, and then the other this is the final result. You see a large posterior ventricular branch, which was the cause of his acute coronary syndrome, and we have reconstructed that. I've done this Z angioplasty in 3 more patients, but now we use guideliner or Godzilla, and that makes the process much more simpler. Now, 86-year-old male presented with chronic total occlusion of Lima and angina. This is the Lima angiography, which shows that just distal to the anastomotic site, there is a total occlusion, and that was the cause of his angina. And we could not go through the native coronary arteries, so we decided to go through the Lima and do an angioplasty stenting of this Lima to LAD. And this is a guide wire being crossed through the Lima to LAD, and then angioplasty stenting was done, and we were able to, after ballooning, deploy 2 stents. And this is the final result you see of chronically totally occluded Lima LAD angioplasty stenting with very good flow, and this procedure was tolerated very well. Now, 87-year-old male presented with acute coronary syndrome and impending shock. Drop was 60. He had multiple culprit lesions, and we decided to do a single stage angioplasty stenting in this particular patient. This is the SVG graft to LAD, and you see 2 lesions here, one ulcerated plaque at the proximal site, and another lesion at the distal site, at the anastomotic site into the LAD. These are 2 lesions in LAD, and then we look at this anomalous circumflex, and there is a critical stenosis here, and his another ramus, which was supplied by a venous graft, had a critical stenosis. So we did an angioplasty stenting of all these 4 lesions in a single stage. This is we had to use a buddy wire because the guide support was not very good. So could not use any protection device because of presence of distal as well as proximal ulcerated lesions, and we did a distal angioplasty and then deployed one stent distally and one plus proximally in the LAD to take care of the LAD lesion. Then we went ahead with the angioplasty stenting of the venous graft to the obtuse marginal, and this is a result after venous angioplasty stenting of the obtuse marginal. And then we did the anomalous circumflex, and after angioplasty stenting, that was done. Now, this is an interesting patient. This is a patient, 88-year-old male. He had undergone a bypass surgery 15 years back, and he presented with acute coronary syndrome. And what we found on his angiography was, this is the left native injection, and you see that LAD, there is a jump graft, and this jump graft is filling from the very diffusely, heavily calcified native circumflex, and then that is filling the LAD. So there is one graft, jump graft, which is filling retrogradely through the diffusely diseased circumflex, and then filling antegrade LAD. So this was the graft which was supplying blood to both the circumflex and the LAD, and it was flush occluded at the ostium. So we had no means of going antegrade into this venous graft. There was no nipple which we could cannulate with a guide catheter. So we decided that we will go retrogradely through this diffusely heavily calcified vessel, do an angioplasty stenting of the totally occluded vessel. After we have crossed the guide wire, snare the guide wire out, and over that pass a guide catheter to establish flow. So we used a CTO wire, and we were able to cross this flush occlusion of the ostium of this jump graft. We caught hold of the snare, and we tried to pull that wire out through the snare, but unfortunately, it would not come beyond the distal aorta, beyond the through the thoracic aorta further because of heavy calcification in the circumflex. We could not take it out, so we were left with the only option to go through the same route where we done cross the lesion. So we did an angioplasty stenting. We had to use a heavy high pressure balloon dilatation at this site. We could not use a rotablator because there was a stent here between left main to LAD. We did a balloon angioplasty stenting of this, and then we went ahead and did we were able to take a 1.5 millimeter balloon and dilate that antegrade. Once we had dilated that, then subsequently using that as a landmark, we were able to hook it with a GR guide catheter, and this wire was through the circumflex. We passed the wire into the LAD antegrade, and then we did an angioplasty, putting only one stent, and I thought that was good enough to take care of the both the jump graft. So there is one stent from this venous graft which is into the LAD venous graft, and then the other graft is supplying the circumflex. So this patient remained asymptomatic for a few months, and then came back with retrosternal chest pain and worsening angina. We did an angiogram on this patient, and what we found that the stent which we had put had got stenosed. There was a critical stenosis, ISR in the stent into this venous graft, and the branch also looked to be not flowing as well. So we thought that this time we should do a bifurcation stenting of this venous graft. Now, there are not too many reports of bifurcation stenting in venous graft. This is actually a left main equivalent venous graft undergoing a bifurcation stenting. We did an angioplasty, passed a wire into the circumflex after high pressure balloon dilatation, and then we were able to, this is the balloon stent being deployed into the circumflex, then crushed the balloon. Using a mini crush technique, we did bifurcation stenting, and this is a stent being deployed in the venous graft into LAD, and we did a kissing balloon angioplasty stenting, and then a pot to take care of the proximal part of the venous graft. So this is the left main equivalent venous graft bifurcation stenting, and this patient has been doing quite well for the last 4 years. Now, 89-year-old male presented with unstable angina, and what we looked at this patient, that this patient had a critical stenosis of left main. And I thought the circumflex, and if you look the caudal view, the circumflex origin looks okay. So I thought that let's go with a single stent left main to LAD, reconstruct the left main to LAD, and if the circumflex gets compromised, then only we will do a bifurcation stenting. So this is the LAD, and we did an angioplasty. You see a critical stenosis in LAD also. So left main LAD stenosis, we did an angioplasty stenting, put in a wire into the circumstances, should it need to be taken care of, deployed stents, and then we were able to reconstruct it with a pressure balloon dilatation and optimization with a larger balloon. The flow was good into circumflex. I thought that we can leave it, and this is what we had a good result in a 94-year-old male. So 86-year-old male had post-bypass, and he presented with unstable angina. And this is what we found. He was so limited despite his age that he said that I need an angioplasty stenting. His venous graft to right coronary was occluded. His lima to LAD was functional, and we saw a heavy calcification of the left main and circumflex, and there is another lesion in the obtuse margin. So the plan was that we do angioplasty stenting of this lesion also, and we do a high balloon dilatation of this lesion. So I was able to get a wire into this obtuse marginal. This is a lima, which is, this again, you see in this view, a heavy calcification at the left main, and the circumflex. Lima was okay, SVG was occluded. So I got a wire into this obtuse marginal, but nothing would go. Even a 1.25 balloon would not go. We used a guide liner, still was not able to negotiate with a small balloon. We were able to achieve some dilatation, but nothing beyond. But look at this bend. So I thought that that bend was quite acute, and maybe the rota wire could not negotiate the rota wire into this obtuse marginal. So put in a rota wire into the posterior, the main circumflex, posterior branch, and then we did a rota ablator of this. Look at the calcification of this. And after some effort, we were able to establish, we were able to get a rota done through, and then we did a balloon angioplasty. And remember, the wire is in the posterior branch, not in the obtuse marginal. And then we deployed a stent into the circumflex, left main to circumflex, high pressure dilatation optimization, and we had a good flow. And I could not take care of this lesion, but look at this angle, rather 90-degree angle, and this was difficult to rewire again. So he left at that. He's quite fine, free of angina, and doing well. 94-year-old female, this is COVID time, and she came just at the beginning of COVID, presented with non-ST elevation marker infarction, and she had a heavily calcified LAD. This lesion is quite critical, although an angio you don't see very well, but once you start dilating it, and there is distal lesion as well. And then we went ahead, did an angioplasty stenting of this LAD and 2 long stents, and look at the second stent, and now you can appreciate the criticality of this lesion. Then we did a high pressure dilatation, and we were able to get a very good flow into this LAD in a 94-year-old female, and she's free of symptoms. Another 90-year-old male had undergone a bypass surgery 70 years back and presented with unstable angina. These are native vessels, both severely diseased, and this is the venous graft, which was the cause of angina. And this, you look at 2 lesions, 2 ulcerated lesions, and I thought that not much of thrombus. Maybe we can do it without putting a distal protection device. We did an angioplasty. This is the lima, this is the venous graft, and we went ahead and put 2 stents in this venous graft. And after dilatation of the stent, this is what we got, very good flowing venous graft into the obtuse marginal branch. 88-year-old male presented with the recurrent VT, and this is what we see on. In fact, in our emergency, had multiple ventricular tachycardia. We took him from the cath lab, from the emergency straight to the cath lab, and you see a critical lesion of the left main. And here I thought the circumflex was a relatively larger vessel, at least 2.75 millimeter vessel, and we should do a bifurcation, the stenting in this patient. This is the right coronary, and you see the right coronary is also diseased. I'll show you after some time. And we did a balloon angioplasty of the circumflex, put in a wire in guide wire, then mini crush technique. This is a stent in the circumflex, then stent in the LAD, and post-dilated, did a POBA, and did a kissing balloon angioplasty, repeat POBA, and then we were done. And this is what we got on the left side, bifurcation stenting in an elderly gentleman, left main bifurcation stenting. So 93-year-old male, post-bypass in 1988, PTC stent to right coronary in 2011, presented with unstable angina. And this is, he's a very active gentleman. In fact, I've done angioplasty stenting of his wife also, and he was limited by this angina. So we thought that his circumflex native was the cause of disease symptom this time. This is the right coronary. You see a diffuse disease in the PDA, but not much could be done to that. And this is the Lima to LAD. And we did an angioplasty stenting of his native circumflex. And this is the final result which you see after 2 stents, high pressure balloon dilatation, post dilatation. You see good flow, and he's angina free and doing well. Now, 94-year-old female with a nephropathy, old CVA, on permanent pacemaker, presented with angina on exertion. And we did his angiography. You see there is a critical stenosis in the LAD proximal, and the obtuse marginal has a critical stenosis. And look at the LAD. LAD just after the diagonal also has another lesion. So we went ahead and did an angioplasty stenting. Look at the calcification of the mitral annulus. Heavily calcified arteries. We did angioplasty stenting of LAD. This is wire in diagonal LAD, just to be sure that the diagonal doesn't close, large vessel. We were able to get 1 stent into the LAD, did well, and then we went ahead and did a circumflex angioplasty stenting, obtuse margins angioplasty stenting, and this is the final result with LAD angioplasty and stenting in a 94-year-old person. 82-year-old female, presented with exertion angina for 2 months. And this is the angiogram which shows that LAD, mid-LAD is near total or 100% occluded. And the right coronary is also filling retrogradely. You see this right coronary filling retrogradely, and this is the LAD, which is totally occluded. And look at the heavy calcification. And this is a little flow into the LAD. We can call it a 99%, but heavily calcified artery. This is a right coronary filling retrogradely, and right coronary, as expected, had a chronic total occlusion and an intracoronary collaterals, and it was retrogradely supplying the LAD. Look at the length of the lesion in LAD, almost till distal LAD. And this is the right coronary again. We see the LAD. So we went ahead and did an angioplasty and stenting. Crossing this lesion did take a little time. Ballooning was, we got 1.5 millimeter balloon, and we were able, then 2 millimeter balloon. And then we were able to establish some flow into this LAD, change the wire, and then we thought that we should do a lithotripsy in this patient. So we took a 3 millimeter intravascular lithotripsy balloon and did a intravascular lithotripsy of LAD, and multiple shocks were desired. You can see the entire calcification. In fact, the lesion was lithotripsy, and then you see this multiple sites being taken care of. And we had a good flow after that, and we thought that we were done in the state, and put in 2 stents, long stent. We knew the lesion in LAD was long, put in 2 stents. This is the second stent coming up. And lo and behold, when we were doing a post-stent dilatation, this is a post-stent dilatation being done, and we had a rupture here and massive tamponade and hemodynamic compromise. So we put in a femoral line, and I don't have cine angios of that. put in a 7 French guide catheter. We did not have a papyrus, so took the normal Abbott stent graft, and we were able to deploy that after using a guide liner. We had a 7 French guide, and using 2 guides, one for balloon inflation to occlude the perforation, and then we were able to negotiate the wire and put in this stent graft here, and this is a final result. So we started with lithotripsy, ended up with lithotripsy and a perf taken care by the stent graft. His right coronary needs to be taken care of. Now, this is an 89-year-old male person, and he presented with angina. And what we see is that there are 2 lesions in LAD. And if you see, you will get an impression that this LAD, these are discrete lesions, and you should be able to get the wire and balloon and stent and everything very nicely here. So that is what we thought. We went ahead and did a balloon angioplasty, and look at the calcification. After that, nothing would go, despite this discrete lesion. And this is the right coronary. And right coronary also had critical lesion at this thing, and I'll show you a better view of showing stenosis in the ostium as well. And then we use a buddy wire and then guide liner. And after guide liner, we were able to deploy stents in this LAD. Lesions which looked very innocuous because of his age, heavy calcification. We ended up reconstructing the LAD. The entire calcified area was taken care of, and this is the final LAD. And then we went after the right coronary. Again, the same problem. Buddy wire had to be used, guide liner had to be used. Then we were able to do a balloon angioplasty, put in a long stent, and after putting a long stent, and we needed another stent. Look at this angiogram and look at the ostium. The ostium is critical narrow too. So we put another stent covering this ostium of this right coronary artery, and subsequently the patient angioplasty was okay. 83-year-old male, he presented with angina, and he did not present with angina. In fact, he presented with multiple TIA, and angiogram was done outside, and it was thought that the carotid is very critically narrow. There is heavy calcification and probably not amenable to angioplasty stenting. So I did an angiogram too, because it was his age, coronary angiogram, and I knew that there was a lesion in LAD, and we decided to go ahead with angioplasty stenting. I was able to cross this with a distal protection device, did a balloon angioplasty, put in a stent, and did a high pressure dilatation with a 5mm balloon, and the flow was very good. But what happened after that was, this patient started complaining of severe retrosternal chest pain, marked tachycardia, had significant drop in blood pressure, and there was a 4mm ST depression in anterior lead. There was a lot of sweating. So we left the carotid. We had achieved a very good result, went ahead after this LAD, and it was a very heavily calcified artery. And this is of that time when we did not have guide liners. So getting anything through this band was extremely difficult. And so what I did is, I put a bare metal stent, a small bare metal stent in this band, and through that put another drug-eluting stent, long stent, and he did very well. 84-year-old male, hypertensive for 10 years, non-diabetic, presented with sudden onset chest pain and with pulmonary edema. And ECG showed significant ST depression. Look at the left coronary artery, which is 100% occluded just after the ostium. Right coronary angiogram, normal flow, but there is some flow into the left system, circumflex, and some LAD, and we also see the left main. So acute on chronic, left main occlusion, presenting with acute coronary syndrome and pulmonary edema. So there was no time to contact the surgeon. We went ahead, put in a wire. We were able to get some flow into the LAD, one wire, and the circumflex still had no flow. After some time, we were able to get the wire into the circumflex also, did a balloon angioplasty stenting, and balloon angioplasty of the circumflex. After that, we had good flow into the LAD circumflex, and then we did a bifurcation stenting of this left main. This is a stent into the circumflex, and then we had a stent into the left main to LAD, and final kissing balloon and optimization by pot. We were able to get very good result in this patient of total occlusion, acute on chronic total occlusion of left main in an octogenarian. This is the final result which we got. Now, 93-year-old male presented with acute inferior wall myocardial infarction. Coronary angiogram showed a left main and a triple vessel disease with a thrombotic occlusion of mid-RCA. And this is the left coronary system. You see there is a ostium of the circumflex is also critically narrow. You may say that there is a proximal LAD disease as well. There was a mid-LAD disease as well, but the culprit lesion was the right coronary, and you see some flow into the mid and distal right coronary artery, but the disease is starting almost from the proximal right coronary. Heavily calcified vessel. We were able to get the wire here, do balloon angioplasty, high pressure balloon dilatation, and after putting in 5 stents, we were able to get a normal reconstruction of this right coronary in an elderly gentleman. 93-year-old person with pre-cardiogenic shock or impending cardiogenic shock underwent right coronary angioplasty, and he refused the left coronary intervention at a subsequent date. He was doing okay. 85-year-old male presented with unstable angina. Coronary angiogram showed a left main with a triple vessel disease, and this is what the left system looks like. There is a critical LAD disease, ostial LAD disease, mid-LAD disease, proximal circumflex disease, mid-circumflex disease, and right coronary 99% lesion. So he underwent a single-stage angioplasty stenting of all the 3 vessels. 85-year-old patient had multiple comorbidity, COPD, angioplasty stenting of the LAD, then circumflex, and after high pressure dilatation, we had a V stenting in this patient. This is the left system showing good flow into the LAD circumflex. Then we did a right coronary angioplasty, put in a stent and high pressure dilatation with a larger balloon. And this is what we finally got in this patient. So all 3 vessels taken care of in an elderly gentleman with critical triple vessel disease. 83-year-old male presented with crescendo angina for 1 month. And he had multiple ST segment. Almost all the leads in ECG showed severe ST segment changes. T wave inversion, ejection fraction was 30%, and there was a moderate mitral regurgitation. I would like you to have a close look at this coronary angiogram. This is the left coronary system, and you see the diagonal, and the LAD is totally occluded after the LAD, after the diagonal branch. And this is a circumflex, the posterior circumflex, and the circumflex here is totally occluded, 100% occluded. So 100% occluded LAD, 100% occluded circumflex, and what we find on the right coronary, this is the circumflex, which is a large obtuse marginal branch, near total are 100% occluded. And let us look at the right coronary system. LAD, obviously 100% occluded. This is the diagonal which you're seeing. And then we did the right coronary angiogram. And you see the LAD here. And the right coronary showed that multiple views of LAD to show you the lesion, 100% occlusion, circumflex 100 plus occlusion. This is a conal branch, and it is supplying LAD, and we know that distally the LAD is good. And then we look at the right coronary. This is again the conal branch, injection showing retrograde filling of the LAD, and then we have the right coronary. And right coronary critical lesion in the mid RCA, and near total or 100% occlusion in the right coronary distally before the bifurcation into PDA and PLV. So we have 100% occlusion of LAD, 100% occlusion of circumflex, and near 100% occlusion in the right coronary. So how do we go about it? Now, which is the culprit lesion? Is the right coronary culprit lesion? It is LAD, is it circumflex, or all 3 of them? So I thought because of the fact that the clot is sticking to the right coronary, we should open up the right coronary first. This is the right coronary wire distally, and we did an angioplasty stenting of this right coronary, and after putting in 2 stents, we had a good flow into the right coronary. This is the first stent. and then this is the second stent, and we had post dilatation with a high pressure balloon dilatation. Then this is what we seeing, the final result on the right coronary. This is a mid of the night procedure with very little technical support available. So right coronary, this is the final right coronary showing very good flow, but the patient continued to be symptomatic. Hemodynamically unstable, high inotropes, saturation 88%. So I decided, let's go ahead and take care of this LAD. And now I see some clots sticking in this obtuse marginal also. But I thought that was a non-dominant artery. We could go ahead and open the LAD. And this is the diagonal. And then we got a wire across into the LAD, balloon angioplasty, some flow being established into the LAD, and put in one stent into the into the LAD. And then finally optimized with the high pressure balloon dilatation. And this is what we got subsequently. Now you see a very good flow into LAD has been established. There was a lot of temptation to do the circumflex, but I stopped here. So we had 3 vessel, total occlusion, in cardiogenic shock, in middle of night with multiple culprit vessels. And we did a right coronary and LAD to take care of that. This patient did very well and was discharged in a stable condition. So I could not stop myself presenting a patient who was a post-CABG, post-infrarenal aortic aneurysm. This is a 79-year-old gentleman. He's not 80. And he came to us in shock. And when we did his angiogram and a CT angiogram, we found that he had multiple aneurysm. This is the left iliac artery angiogram, you can say, and there is the internal iliac artery, large aneurysm on the left side. And then you see, and we went, I'll show you the subsequent procedure a little later, and after we were able to delineate the origin of this iliac artery, separate the the bifurcation site, and put in a device, occlusion device, ADO occlusion device, to block this aneurysm into the internal iliac artery. And then this is what we get finally after optimization. This is the flow was occluded, and now you see the flow is occluded, and there is hardly any flow into the aneurysm into the internal iliac. And then we had the right iliac artery, infrarenal aortic aneurysm, and you see there this leak, this huge leak. In fact, whenever we would try to pass in a wire, the wire would go into this large aneurysm, and this is a leak. So we decided to put in a stent graft, the ipsilateral limb of the AAA here, and this is a 18 millimeter. This is a balloon-mounted stent graft, and we deployed that, and that was able to take care of this rupture, optimize it with a larger balloon. And the third aneurysm he had was in the pseudo aneurysm into the splenic artery, and this also needed to be taken care of. So we deployed multiple coils in this. You see the calcification in the splenic artery, and the multiple coils were deployed to take care of this splenic artery aneurysm. You see the flow has occluded, and after more coils, we were able to finally establish a very good occlusion of this aneurysm. So one was the aneurysm in left internal iliac artery. The right iliac artery was a rupture with free flow of blood, and a splenic artery aneurysm. All three were taken care of in a single sitting. Now, what I'm going to present to you is my team's or my experience of tackling octogenarians and nonagenarians since 2007, when I moved out from PGI. We analyzed this data, and we done 248 patients. This is a consecutive data. I do not have any experience of fibrinolytic. No, I have one, because after the COVID, I used in one patient a fibrinolytic treatment. But before that, I had no experience of using fibrinolytic treatment. All patients, whether either underwent a primary angioplasty or they needed revascularization, they underwent a procedure. So 248 consecutive patients above 80 years of age. Predominantly male, that is the worldwide experience. We are a male chauvinistic society, and that is what the age groups are. As I said, one patient was more than 102. Probably this other Saint G also was more than 100 years. Some percent is stable. This data is being still analyzed, so I will rush through that. And cardio biomarkers, some patient adrenal failure, and more patients had a femoral intervention than, because many of them had post-bypass procedure, or some needed additional devices. Therefore, femoral route was used more commonly. Normally, almost 95 to 96% patients of ours these days are radial first. But if you need a femoral, there is no issue about that. And most of the patients had triple vessel disease. Some had single vessel. All vessels were taken care of. And length of stay was, in 165 patients, it was less than 3 days. So large majority of patients could be discharged in less than 3 days. 50 patients stayed from 3 to 5 days. 29 patients stayed from 6 to 10 days. And only 4 patients had a long stay of more than 10 days. We had 8 patients who had bleeding local because of femoral, and that was taken care of. 8 patients had contrast-induced nephropathy in this group. 6 patients of this were cardiogenic shock. So ours is the single largest reported experience of PCI in octogenarians from single center in India. So what we conclude from here is that PCI in selected octogenarian is safe and effective, and we can do a complete revascularization if required in these patients as well. We prefer radial route because of lesser complication, shorter hospitalization, and early embolization, which is ambulation, which is a norm in radial. And if we can do a radial, that's what we do. But we need to remember that some of them, they have even a subclavian artery occlusion also, and radial may be a little tougher. And in this journey, a number of my colleagues, some of them from PGI, have been very closely associated. Initially, when I moved out, we had Dr. Shiv Baga. Today he is in today he is in US, and he would be starting his fellowship in Mount Sinai shortly. Kapil has been associated with me for a very long period of time, up till 2014, and then again for the last 1.5 years. Then we had Dr. Fazal, a very accomplished interventionist. He was here for some period of time, maybe almost close to 1.5 to 2 years. And then we had Himanshu. There was a time when we had both Himanshu and Fazal, and that was academically a very satisfying time for me. And Himanshu was there. And then we had Navdeep. Himanshu, of course, is doing very well in PGI after some more training in Singapore. And then we had Navdeep Sidhu. He's now in Faridkot Medical College, doing quite well. And we have Amreen, who sometimes does scrub in the cath lab. But these people equally important role in all these complex interventions, and I express my thanks to all of these people for sticking with me despite my mood and my occasional bus. And what I would like to say, thank you at this time. And if you have time, then I'll go ahead and present Valve TAVR. I think I've taken a lot of your time.
So, thank you very much, Dr. Bali. We didn't have the chance to introduce him, not that he needs any introduction, but I must put up my hand and say that, I was lucky enough to have interacted with him during my cardiology residency, and all of you who heard this will definitely agree that, the fire of intellect that burns within him illuminates and educates everybody who is lucky enough to.
Hello, can you hear me?
Listen. Yeah, we can hear you, sir. Am I audible, Smith?
Ajay sir, you have to be a bit loud.
Okay, so I said, once again, thank you to Dr.
I can't
Bali
hear.
for that masterly exposition. Smooth, why don't you speak? I can't. Maybe there's something wrong with.
So, sir, we are very thankful, sir, and it was a very enlightening talk. And we can have, if you allow us, we can have it the TAVR case for the 10 minutes, and then we can have 20 minutes of discussion on both the cases. And there are few questions which the panelists have, the audience have asked. One is by Dr. T.P. Singh, that what is antiplatelet regime in this age and the duration.
So I can't hear anything.
If Jay, you can take over if my voice is also not coming.
Hello, sir. Am I audible? Bali, sir? I think probably an issue with the
Yes, sir,
audio.
you're audible.
Yeah, you're audible to all of us. You're very clear to rest of us.
But I think Dr. Bali is probably not able to hear what we are.
Hello.
Ajay sir, you have to use the mic. And the questions are in the chat box. I can just repeat. Sumit Kumar has asked, how do you take care of contrast-related AKI in elderly patients? And then culprit vessel versus complete revascularization in elderly patients.
Sumit, I can't hear you very well.
Sir, I'll call you.
Bali sir, are you able to hear me?
On
Hello?
my phone, not on my computer.
Hello.
Okay, tell him to speak in the phone only.
Yeah.
Ha, Ajay, I can hear you. Hello. Okay.
Jinx, Dowdy of the Nigurda.
Okay. As far as antiplatelets are concerned, a lot of my patients continue to be on clopidogrel along with aspirin. It's only recently, for the last about 6 months, I have started using ticagrelor in some of these patients who are ACS along with 75 milligram of aspirin. And I try to bring it down to ticagrelor to 60 milligram twice a day as fast as I can. But large majority would continue to be on clopidogrel and aspirin. Initially, for 1 month, I gave 75 milligram twice a day, and then cut it down to 75 milligram once a day, along with aspirin, and that is what they continue on. As far as total versus partial revascularization is concerned, idea is that if we can, we take care of the contrast and other parameters, clinical parameters of the patient. And if we can do a complete revascularization within limited amount of contrast, then we go ahead and do it. But in ACS, we try to stage it. We take care of the culprit vessel, come back before hospital is discharged, and do other vessels subsequently. And very rarely, if the procedure has gone on for a long period of time, then we do it much later. But the idea is we should be able to do as complete a revascularization finally as possible. case is ready. I will just take 1 minute to open it up.
So we are going ahead with the TAVR case, sir. Dr. Ajay. Yeah. Then you can just communicate the answers, sir, for the question.
Bali sir, are you able to hear me?
তো কিবা কৰিছিল নি মাইনা
As far as transcutaneous aortic valve implantation is there, I am new to it, and we done a few cases, and recently we did a valve in valve, so I will just go through that. All of you know about that aortic stenosis is increasing, and when they become symptomatic, then they progress very rapidly. This is a new technique where bioprosthetic valve, which have been deployed in the past, they get degenerated, and the only option either a redo surgery or put in a valve in valve. So my patient is a 70-year-old female. She was a known case of severe aortic stenosis, had undergone a bioprosthetic aortic valve perimount 23 replacement in 2009. There were a lot of comorbidities. She had coronary artery disease, for which I had done angioplasty and stenting 1 year ago. She had chronic atrial fibrillation and hypertension, and now she presented with progressively increasing dyspnea on exertion. On investigation, she was found to have a severe prosthetic valve stenosis with maximum gradient of 104 millimeter, mean gradient of 52 millimeter, Amakri, and a calculated valve area of 0.7 centimeter square. LV function was normal. In view of severe symptomatic aortic stenosis, multiple comorbidities, we had a discussion in our heart team, and patient was reluctant to go for another open heart surgery, so we decided to go for a TAVR. And as usual, a lot of measurements were taken. What was the annular size? What is the height of coronary arteries? And what was the angle of the arch of aorta? And then what was the size of the excess femorals and iliacs? And we were very comfortable that all these parameters are quite comfortable to go ahead and do a valve in valve. And then we proceeded on that, and this is what you see: a valve, bioprosthetic valve, perimount valve, and this is a pigtail. I will just rush you on because I think. And we had a transesophageal echocardiography to guide us, placing wire there, cross the lesion, and without pre-dilatation, which has some issue in valve, which we can discuss during discussion time. We decided to directly deploy the valve, and this is the Evolute or valve, 26 millimeter. And we thought that if we get persistence of gradient, we might have to fracture this small 23 millimeter bioprosthetic valve to get an optimum deployment. So that was the plan. So first we deploy 26 millimeter, see the extent of the gradient, and go ahead if the need be with a larger balloon. So valve was deployed. This you can see The coronaries are very nicely depicted. So there was no problem as far as coronaries are concerned. So the valve was deployed in the normal position what we see, and then this is a complete valve deployed, and there was no problem. After deployment, we post-dilated it with a 20 millimeter balloon and then 23 millimeter balloon, and we had almost negligible residual gradient. So we decided that that was sufficiently okay for us to go ahead and leave it, not go ahead aggressively to fracture the valve. So she's doing quite fine, and we had to give her oral anticoagulants because there's some discussion whether NOACs can be used in such patient or not. But majority view worldwide is that these patients who have chronic atrial fibrillation and need oral coagulation and have a valve in valve should be put on oral anticoagulants. That's what we've done. We're maintaining INR between 2 to 2.5, and she's doing very well. On echocardiography, the gradient is about 4 to 6 millimeter, and there is no regurgitation, so she's doing quite well. So this is a new technique which can be used in this patient. More patients are coming with this problem, and I think we can have discussion on this issue now. I'm not going to the theoretical basis of this particular thing.
Ajay sir, you can take up the discussion part. First of all, I'll request you again that you introduce the panel expert.
Yes, Ajay. I'm audible. You give me a question, I'll answer if they can hear me. That's fine. And we can talk cricket now. See the valve which we deploy, the evolute valve, is a supravalvular valve. So we can actually choose a larger size because 23 millimeter which has been put in, they put it at the site of the valve, at the site of annulus. So majority of these valves, if you look at them, there would be some residual gradient, and we need to have a larger valve. And we can fit in a larger valve because the position of our valve is supravalvular, and the 26 millimeter. And sometimes what we realize now is that despite putting in a larger valve, the original bioprosthetic valve is still constraining them, the new valve in valve. So what we do in such patient is that we fracture the existing bioprosthetic valve, so we can have a larger valve area and more area to expand the valve. So we can use a larger valve. So that is what we decide. If after deployment of the valve, we feel that there is a residual gradient, and the residual gradient should be in single digit. If we find the gradient is more than 10 millimeter, then we should be aggressively dilating the valve, fracturing the valve, and getting an optimum result. And that would also give us a long-term good result. So that is how we go about it. See, initially when the valves came, they were deployed a little deeper. And one of the problem with deep deployment was that you are against the septum, and the conduction tissue is there, and that would produce a higher grade of complete heart block. And therefore, more and more people now are deploying very shallow as you can get, taking into consideration that occasionally you may have a valve which may get displaced, but as shallow as you can get. We try to go 3 millimeter at the outer curve, and that is where we go ahead and deploy the valve. So we go as shallow as possible. And the other is the valve in valve. I don't have too much of experience of balloon expandable as yet, but that would be a little lower, my valve and all. But that is, I would leave you to answer that particular question. But as far as self-expanding is concerned, go as shallow as possible to avoid complete heart block.
Dr. Ajay?
Ajay sir, you can request Bali sir to repeat your question also, so that we are able to hear it.
Yashpal doesn't seem to be hearing you.
Yeah. In fact, Dr. Bali.
Yashpal, can you hear me?
Yeah, I'm hearing you very well.
I can't hear you.
Great.
You will have to go through Ajay Swamy. Okay. What Ajay Swamy asked was that how we choose how deep to deploy the valve in a valve in valve, or otherwise also. And what we have seen that initially when the experience was not very extensive, most of the operator would deploy the valve deep into the, and that would produce more complete heart block because of the conduction tissue presence in the septum. And now with experience, most of the operators have realized that we should deploy it as shallow as possible without actually getting displaced. So what we use is about 3 millimeters below the outer curve, and we deploy it as shallow as possible, and that is how we prevent complete heart block. Then there are specific valves, depending on which particular valve we are using, whether that is a pin valve or otherwise. We have different technical issues involved there. But two major problems in this, what we need to understand. One is conduction system abnormality, and the other is stroke. And stroke would depend on multiple parameters, the aortic arch, how is the aortic arch, how is the carotid, and how much is the profile of the valve, and so on. Another point which I want to make is that when we are going for a valve in valve, we try not to pre-dilate, because there is some apprehension that if we cause embolization. So we don't pre-dilate. We very rarely we pre-dilate. So go ahead with the valve in valve, de novo, and then post-dilate the valve. That is how we go about it. And if the risk of stroke is very high, then you can use the protection device. People have tried to use protection device in the carotid to prevent embolization. And there are devices which are approved by FDA for high-risk patients who are at high risk for embolization. So this technique is improving all the time.
Dr. Bali,
hardware is improving. The valve profile has become much smaller now, and it's a half an hour, 45-minute procedure. Can be done under local anesthesia. You are doing a vascular closure device, so the patient can be ambulatory in one day, and the next day can be discharged. So you should all be doing this TAVR with elderly population, with the aortic stenosis coming up very aggressively. And now, initially it was high risk, then it became for moderate risk, and now the evidence has shown that even in normal risk also, TAVR gives as good a result as a surgical valve. So probably This is one more area which we have slashed, like the Galvan Valley, from the cardiac surgeons, and we should be doing a lot more in coming months to years. This is the way to go. I see TP Singh here with a lot of experience in TAVR. TP, any comments you want to make?
Dr. Bali, I just want to give one comment. Now this lithotripsy balloon used for calcified aortic valve will make this TAVR so simple that it will be done with very ease without any.
Yeah, I saw that presentation. Hajra had also got something back. I would wait for some more time before the judgment can be passed. There was a time about 20 years ago, we used to do balloon angioplasty in patients with severe aortic stenosis, and these patients would improve significantly, especially those who were in heart failure, the left ventricle function would improve. But over a 3 to 6 months, they would come back. So when we talk of lithotripsy, we would have to see a relatively longer term results in that. But that is obviously another addition to our armamentarium. And yeah, I think this is a very, very important question. Contrast nephropathy is the problem because these people have borderline compromised renal function. So whenever possible, we try to admit them a day or 2 days earlier. We hydrate them very well. That hydration is the only factor which has been shown to be very useful in preventing contrast-induced nephropathy. We try to use VisiPack in these individuals, and despite the fact that there is not much trial data to show the role of acetylcysteine, we still use acetylcysteine in these individuals for at least 2 days, and then we limit the contrast. We non-ionic contrast, VisiPack, and we try to limit the contrast as much as possible. These are the only factors which have been shown to be effective in preventing contrast-induced nephropathy. The question of remote conditioning came along sometime, that you put in a cuff, in balloon cuff, BP cuff, and then you inflate, deflate, and produce a remote conditioning. That has been shown to be not useful anyway. Another concept came that you can put in a catheter in the coronary sinus and take away the contrast as much as possible. That did not show much result and very Therefore, the only few things which make a difference is hydration, limitation of contrast, use of VisiPack, and as small a contrast as possible. These are the only factors which make a difference. And if you are expecting large amount of contrast to be used, that is one of the very strong indications to stage the procedure. So that is what we go on. As far as the calcification in the coronary is concerned, they have huge calcification. And I use a rotablator in less than about 7 to 8% of my patients, and a large majority of patients can be managed with high pressure balloon dilatation. We have an opium balloon which can go to 35, 40 atmosphere also. We use a smaller balloon. When we find calcification which is consistent, we go with a small balloon, dilate it a little bit, and then go with a larger balloon. So we use a lot of high pressure balloon dilatation. But whenever rotablator is required, that they also used, as I showed you, and some patient we may have no other alternative but rotablator. Lithotripsy is a very, very promising technique, very simple to use. The only limitation of lithotripsy I can understand today is cost. it is extremely costly as far as paying capacity of our patients is concerned. The other problem is not in India, but elsewhere people have found that balloon rupture is an issue. But we have not found that. Cost is the only factor. And you can also combine lithotripsy along with the tablet. So there are a number of techniques by which you can take care of these things. And I believe that in heavily calcified lesion, it's a good idea. I have not shown you though. It's a good idea to use some sort of an imaging technique to see that finally balloon dilatation and dilatation you have is optimal. And especially when you do complex procedure like left main bifurcation and all, it's a good idea to have imaging to see that the stents are fully expanded and they are fully well deployed.
Ajay, regarding nephrotoxicity, Dr. Bali has already elaborated very well. But 2 points I want to just add that in PGI we never take nephro consultation for any creatinine 4. We make that creatinine 4 to 1.52 by increasing the hematocrit, hydration, correcting sepsis, and other factors. All the PGI alumni, you might have seen that by improving the ejection fraction, decreases the creatinine at this one level very much. Further made a very good data in PGI of that, and we will be publishing that. In fact, the creatinine is a misnomer. It is because of LV dysfunction, anemia, sepsis, and the kidney size sometimes mildly decreased. So in majority of the patients, it's reversible. So, and secondly, by diluting the contrast, by just taking 50 ml and making it to 150 and 1 or 2 injections, we never saw any creatinine rise for the last 7-8 years. So never any patient required dialysis or any rise in creatinine. Rather, the creatinine becomes better after angioplasty as well as this. So this is a new invention from PGI. I think many of you have seen there when you were there. In the last cardiac center. Samita, are you listening?
Yeah, I think it's a worldwide experience now, and large majority of people would use iron in these people, and that depends on they should be have good hemoglobin, and their iron score should be very good, and that not only helps in oxygen carrying capacity, but also decreases ischemia. And in some patients, it is very useful. And now that the iron has become so patient-friendly, you should load your patients in the CCU with iron, intravenous iron, and maintain their good. That definitely makes a huge difference to them. But some of these patients need to be taken to cath lab straight away. So I would not say iron or angioplasty. I would say angioplasty plus management of these patients with all. They may have anemia as an important contributory factor. Even when obviously the hemoglobin looks good, they may have iron deficiency. So all these are factors which need to be taken care of. When they give time, they do give them iron before the procedure. You should do that. But that is rarely the case. So before these patients are discharged, you should load them with iron, depending on what is their hemoglobin level, what is their ferritin level, what is their saturation level, and so on.
The thing is, the patient elective and other patients should always be taken with correction of hematocrit so as to decrease the mortality of 5% at 1 month and 10% at 1 year. So that is most important.
Yeah.
Most important. Ashokan, are you listening, please?
Some problem with audio. Not able to hear properly. Able to see Bali sir. Great thing.
Yeah, I was really very happy to see Pattam when Pattam then was in ward, and I told him that ejection fraction will be
After many years, they able to.
his eyes were on the roof. And he said, "Sir, how it can happen?" Then I told him, "Pattam, go and do echo, because I have already done for 2000. So he is the person resident.
Bareilly is very, very good, excellent cases.
Can't hear.
Sorry, I used to say Pallab.
Nice to see you, sir.
Dr. Bali, really very great cases and this octogenarians, calcified vessel. But as you know now, the technology is very coming. With shock, even cardiologist lithotripsy is doing so well. We did 2 patients in shock with ejection fraction 10-15% about 2 days back. So it is becoming just a staged angioplasty. So this one, that every patient, a patient will not be going for surgery, because those patients who are rejected by the surgeon or by the angioplaster sometimes, because if they were not there, so they are being managed.
I think post to unmute everybody, only allow one person to speak, otherwise won't be able to speak. It's a problem. The audio. Allow one person to talk at a time. Yeah. Now we'll discuss. I think we can. It's a great case what Dr. Bareilly has presented. I think it's we see a lot of elderly people. What the practical difficulty what we face is calcification, tortuosity, and the complication in the vascular side. I would like to know Professor Bareilly's experience in this aspect.
Hello.
No sound, please.
By the way, Dr. Smith, can you hear me?
I think there is a sound gap among many.
Sir, I think most of the questions for today are answered. And the rest of the questions, we all know Dr. Bareilly is also the principal. So we can approach him anytime and he'll be glad to answer our questions. So we can take that. It was a successful one and it was a very learning for every one of us. Meet again after 2 weeks on Saturday night.
Thank you. It was very nice work. Very good lecture by Dr. Bareilly. Thank you. Very good. Shokan, you keep on treating COVID patients very well in Kerala, which we are discussing. So, thrombolyze 2B, 3A, sepsis treatment, iron, albumin, patient will become negative, and the no transmission will be there. The Dubai has won the war. They have celebrated just like Diwali, because you were remembering that Dubai people said that after thrombolysis, they became so happy. They were even not knowing the dose. So we have claimed that in future, 5 lakh patients, this died. In the next 2 years, 10 lakh patients will be saved even after COVID, because there are so many sepsis which are there go undetected.
Professor Espal, we are discussing 2 things. One is COVID case. We are discussing non-COVID now, the complex case.
But
that's the point. That's the point.
I was discussing
last time I presented a staff clinical meeting in 91 was 1999.
Well, then you can
when we did a carotid and an angioplasty in the same patient. And otherwise, I did not know whether the slide will run or not. So these are the 2 points. I'm not too tech savvy.
Yeah, you're right. You're right. So I think
now these are very good
interventions in octorians and elderly people.
Life of a doctor and healthcare worker is also equally important.
Takes you back in time frame. And it's been 13 years since I left PGI. It's a long time. So many of them I don't know But please convey my good wishes to each one of them and tell them to stay connected. Absolutely. Absolutely. Fantastic.
And can I ask some questions now?
Whatever
or
we are,
discussion?
it's very, very largely towards that.
What answer you want to?
Culture. And the type of people which come from all over the country. You come to know the country. You come to know everybody. It's huge. And that gives you the confidence to stand up anybody, to up to anybody in the world. That's a confidence which you have. So thank you very much and take care.
Dr. Bali, Mandeep Singh came to PGI. Mandeep Singh from Mayo and Peter, they were really surprised to see the VSR patients in a row, 4 patients surviving with sepsis, with cardiac shock. So that is very, in that way, approach as you have taught us also, patient-specific approach. If the patient is having sepsis, for which the futile prognosis has gone, so our teaching should be very, very clear for those patients that never forget thrombolysis, because our thesis and this one comparing rescue deferred PCI, this value thesis, I was doing lot of primary angioplasty, but there used to be 10% mortality, 5% to 7% of cardiogenic shock, this one ACS, including cardiogenic shock. So basically, we should give them message that patient-specific approach and precision cardiology should be there, because these are our future, this one cardiologist. They were student here, but they will become very great cardiologists in the future. Ashokan, are you listening?
Yeah, listening. Yeah,
So
your point is well
Dr.
taken.
Bali's
Yeah.
phone connection is not good.
Yeah, there's some problem with the connectivity and the audio also. I think we had a good scientific discussion. I learned a lot of points. I think it's initially presented very complex cases, and the approach to elderly with multivessel. And later, I think it's the valve where I could not hear the entire things, the discussion. Okay, Dr. Smith is here, or you have finished the seminar, or you are continuing, or what is the things?
Dr. Wander is connected or not? Sumit? Dr. Gurpreet Wander?
Okay, I'll see you then. Bye.